Fire in the OR. Fires in the OR are rare, however, the results can be devastating, causing serious injury, disfigurement, and death. One study estimated as much as 650 surgical fires occurred annually in the U.S. However, other studies hovered around the 100 mark. Regardless, the likelihood and consequences of a fire are real in every OR. The reason for this is the availability of many sources to complete a fire triad. 3 components to complete a fire triad include an oxidizer, fuel, and ignition source. All 3 are necessary for a fire to start. Unfortunately, these items are available in every surgery, making fire reduction strategies integral to patient safety. Surgical fires can cause preventable patient harm, from minor to major burns, infection, disfigurement, extended hospital stays, and psychological trauma. Oxidizers such as oxygen and nitrous oxide are extremely flammable. As oxidizer levels increase, the ignition temperature for fuels decreases, making it more likely to start a fire, especially during procedures involving surgical sites above the patient's xiphoid process. This risk is higher when using open oxygen delivery systems such as nasal cannulas and masks. A large variety of fuel sources are available during surgical procedures. The use of alcohol-based preoperative skin antiseptics are highly recommended for decreasing microbial counts effectively. However, alcohol-based products contain up to 70% alcohol, posing fire risk. Additional fuels include sponges, towels, foam padding, surgical drapes, which burn quickly when they are dry. Other items we do not generally think of as fuels include endotracheal tubes, oxygen masks, nasal cannulas, dressings, ointments, surgical gowns, blankets, suction catheters, flexible endoscopes, fiber optic cable coverings, gloves, packaging materials, the patient's hair, and gastrointestinal tract gases. So many hazards. Ignition is typically instigated by energy-generating devices. The most common source is cautery from the device itself or heated tissue. Surgical lasers can ignite a fire if the beam contacts a fuel source or if the fiber is cracked or frayed, leading to escaped energy near combustibles. Fiber optic light cords distribute heat through the cable and optic apparatus, which can directly burn a patient or create a burn through the surgical drapes. Additional ignition sources include high-speed drills and burrs, bipolar electrical surgical units, and defibrillator pads. In a report of 70 OR fires in Pennsylvania, the most common ignition source was cautery, followed by fiber optic light cables and lasers. That's what it looks like, fire triangle. Risk reduction and prevention. Surgical patients tend to be higher acuity, not ambulatory, if anesthetized, and are in an isolated environment that contains multiple sources to complete a fire triangle. So how do we mitigate the risk? As part of a surgical safety checklist, we should include factors that increase the risk of fire, such as performing procedures above the xiphoid process and using alcohol-based skin antiseptics, oxygen, electrosurgical devices, lasers, fiber optic light cords, burrs, saws, and or drills. This has been an adopted standard practice in the U.S., so it's part of their timeout, every case. High-risk reduction strategies include using a holster for cautery when not in use, inspecting electrical equipment, ensuring cords are intact, minimizing pooling when prepping with alcohol-based solutions, using tuck towels if prepping to medline and removing them before draping, and allowing flammable skin antiseptics to dry before draping. Place lasers in standby mode when not in use, which we're pretty good at. Connecting light cables before activating light sources, and switch to standby mode when not in use. This is real. I've actually burned a drape because it automatically turned on. Not good. They weren't burned, but it could have been. When using high-speed drills or burrs, the scrub nurse should use irrigation to reduce heat. Ensuring that communication occurs between the surgeon, circulator, and anesthesia before initiation of cautery. When opening, oxygen delivery is required. Promote healthy communication among all members of the surgical team to support a culture of safety. Surgical fires can be preventable, and when they do occur, perioperative team members should react quickly to implement strategies to protect the patient and staff members from injury. Tools such as fire algorithms and checklists should be posted in every OR for a quick reference. This is an example of different roles and how you can influence the fire triad through your scope of practice. I think you want me to read it too, right? Right, risk reduction example. So a patient was taken to the OR to undergo laparoscopic subtotal colectomy for adenocarcinoma After resecting the segment of the colon where the tumor was located, the surgeon realized that he had accidentally lacerated the bladder. The laceration was sutured without difficulty, and an order was given to irrigate the bladder to ensure its wall was intact. During reanastomosis, in the darkened laparoscopic suite, the nurse set up the bladder irrigation equipment and began the flush with warm saline. No one noticed when setting up the equipment that circulator had hung the 3-liter bag of solution from the hand of the anesthesiologist's accessory monitor, directly above a major transformer that powers the device. As the procedure continued, the bag of saline dripped directly into the power inverter. Suddenly, sparks and flames began shooting from the monitor, and the OR quickly filled with black smoke. What are you going to do?
Unplug the power source.
You're going to race. Oh, yeah.
Race.
Is everybody familiar with this?
Yes.
All the things. So, rescue anyone in danger, alarm or alert others of the presence of fire, confine the fire, and extinguish the fire if it can be safely done or evacuate. Make sense? Wait, there's more. Responding to fires in the OR is quite complex. Using RACE to organize the response is helpful. So, rescue, alarm, alert, confine, contain, and extinguish, evacuate. Implementation of RACE is determined by fire-specific factors such as the location of the fire. Rescuing a patient involves controlling the factors causing the injury in order to prevent further injury. Implementing the rescue action in an airway fire doesn't necessarily mean moving the patient to another location. In this instance, airway gases need to be stopped immediately. Rescue also applies to protecting members of the surgical team. If the situation, such as a spreading fire in the next OR, warrants moving the patient, we need to be aware of our evacuation routes, along with items you need to take with you, like the patient's chart, medications, and special devices and needed equipment. If you do need to relocate, these grab-and-go items are quickly collected, avoiding delays in evacuation. Moving to another area or staying in place is influenced by the presence and location of smoke compartments, which are created by barrier doors that close when fire alarms are activated. The fire and smoke barrier doors close off affected areas containing smoke or fire and prevent the spread of fire and toxic fumes. Does everybody know where they are?
The fire doors?
Yeah.
Should be the far door.
Car door.
Door doors.
Yeah, most all of the double doors
Yeah.
will automatically
This
shut. Yeah. But also there's a magnet one on the corridor, so that'll switch shut too.
Yeah.
The back entrance. Alarm or alert. Whoever notices the presence of fire should first call out fire to alert others. If anesthesia notices an airway fire, their first call for help may be to the scrub nurse for saline or wet sponges to put out the fire. Meanwhile, the surgeon hearing this will be assessing the clinical situation and formulating initial plans, such as determining whether it's appropriate to stop surgery, ensuring hemostasis, and considering whether and how the patient should be moved. Simultaneously, the circulator hearing the announcement should contact the charge nurse, who can gather additional help. Team members should use emergency code buttons, phones, and other forms of communication through the crisis. Confine and contain. Fires that start in your OR necessitate immediate action to protect the patient and staff from fire and smoke injury. Staff should work to prevent smoke and fire from entering the ORs. Communication with colleagues outside the affected OR is necessary. If a fire starts outside your OR, the initial actions of containment will focus efforts on isolating the patient and your OR during surgery. This requires communication from someone outside the affected OR, like your charge nurse, who can notify the surgical teams that there's a fire in the OR or in an area near it. This allows the circulator and other team members to actively prevent outside smoke from entering their OR. Preventative actions start with closing the doors and sealing the space between the bottom of the door and the floor with moistened towels or other materials to block smoke from entering your space, and obtaining additional saline solution or water. And then extinguish or evacuate. Although the option of extinguishing a fire or evacuating is the last component of RACE method, when airway fires occur, it becomes the first and most important action to rescue the patient. Then the pass method. Everybody familiar with that one? What to do with a fire extinguisher?
Activate, sweep, and
Squeeze
squeeze and sweep.
Remember to aim at the base of the fire.
Aim.
Unless it's on your patient. Maybe don't suck all the heat out of the space. Squeeze slowly, and then sweep side to side at a safe distance from the fire. Okay, algorithms. I got these from ARRN in the States because they're very risk averse. We're gonna use these later. So one is crisis considerations, fire safety in an airway fire. Another one's non-airway fires. We'll talk about that in a minute. There's another algorithm to follow in a fire. And so that we have options to use later during our mock. Right, airway versus non-airway. Patients are at greatest risk of fire injury when all three elements of the fire triangle are in close proximity, which occurs during surgery, particularly performed on the head, neck, and upper chest. Patient risk is higher because the surgical site is near the patient's airway and includes an endotracheal tube or mask delivery of oxygen. The Joint Commission reported in a Sentinel event alert the location of the majority at 62% of fires were on or in the patient's upper body, with airway being at 34% of that and face or head at 28% of that. Airway and non-airway fires. This distinction between airway and non-airway fires is important because an airway fire not only jeopardizes oxygenation, but can also produce severe tissue trauma in the respiratory system, which is very difficult to treat and repair. All right. We're gonna run through a situation for an airway fire scenario, so you can think about things before we do a mock code. A 40-year-old woman with a history of COPD has been in ICU, vented for 6 days. She is now scheduled for trach. In the OR, surgical team members place the patient in supine, then prep and drape her. The procedure progresses uneventfully until it's time to insert the tracheostomy tube. Anesthesia withdraws the ET tube above the carina. At this point, the surgeon notes bleeding from the tracheostomy site and uses the cautery to stop the bleeding. The circulator sees a spark and quickly unplugs the device. The surgeon and the scrub nurse see smoke coming from the incision. Anesthesia immediately turns off the anesthetic gases. The scrub nurse hands anesthesia and the surgeon saline smoke sponges to extinguish the flames. The circulator presses the cold button. The charge nurse brings a difficult airway cart into the room and hands the circulator fiber optic scope. After anesthesia extinguishes the flames with the saline sponges, they assess the airway with the scope, perform an endoscopic bronchoscopy to view the patient's airway, then reinsert the ET tube. Anesthesia successfully reintubates the patient, and the patient's oxygen saturation is satisfactory. The surgical team members return the patient to ICU for recovery and further observation. The scrub nurse and charge nurse grab implicated supplies like ET tube, cautery, and drapes, and the surgeon, anesthesia, and circulator document the details of the incident. The surgeon notifies the family that there has been a fire, describes the patient's current status, explains the treatment plan, and identifies how we can keep the family informed about the patient's progress. So that's an example. Now we're gonna go do a mock code or